Respected Chairperson, and thanks to the organizer committee, Dr. Sadikor sir, Dr. S.R. Arvind, Dr. Krishna, Dr. Vijay, and special thanks to the Dr. Bansi Sabu. I think thanks will be very small for the Dr. Bansi Sabu. My talk, at least how to manage the hyperglycemia in the hospitalization patient. Always is a diabetic patient. Always diabetic patient carries the shift in between the OPD and indoor patient. What about the A, B, C, D? At least I think, at least because of the diabetes is a progressive disease and it is having the always macro and macrovascular complications. So that what about admissions, discharge, outdoor patient, and again is going to admission. How to deal with the hyperglycemia in the hospital setting? What about the definition of the hyperglycemia in hospital? We can say hyperglycemia in hospital has been defined and the blood sugar is more than 140 milligram deciliter. We can say this hyperglycemia in the hospital. What about the etiology? These are three possible etiology. Either patient is a known case of the diabetic prior to hospitalizations. Yeah, first time detection of the diabetes in the hospital, and some of the stress hyperglycemia. It can revert the normal after the discharging, during the discharging. And how common is hyperglycemia in hospitalized patients? Definitely India is a capital for diabetes. Most of the hyperglycemia, prevalence of the hyperglycemia in hospitalized patients is very high. Some of the studies are showing hyperglycemia occur in 38% of the admitted in patient, and out of 38, 26% had the prior history of the diabetes and 12% having the first time of the diabetes. These are common conditions in the pre-existing diabetes, cardiovascular, renal, stroke, traumatic, decay, and surgery, and adverse effect of the treatment with a certain steroid. At least these are common conditions. Patient is going to admit with the hospitalization. These are a particular, we can say, 38% of the hospitalization patient having the diabetic. Out of 38, 25% is a prior diabetic, and 13% having the diabetes first time in the So there is a, what about the effect of the hyperglycemia on the hospital mortality? There is a simple linear relation with the, if the sugar is high, mortality is going to high. Particularly the worst part in the ICU, first time detection of the hyperglycemia, were compared with the prior diabetic and prior the admissions, we can see there is a p-value is significant with this particular. So that what about hyperglycemia, poor outcome following acute MI, stroke, we can see. What about the we can see these are linear relationship with the normal glucose, mild IGT, severe GT, and diabetes, and mortality can proportional, and that patient categorized based on the admission with the sugar. Same as usual. Once is a poor outcome correlate with the hyperglycemia with the acute escape. When the patient is going to admit on the admission, if the blood sugar is less than 130, if the blood sugar is more than 130, we can say what our length of the stay, discharge at home, hospital mortality, 30 days, 1 year, 6 years mortality. There is a significant p-value. If the blood, once we are keeping the blood sugar less than 130, you have more than 130. What about the etiology? Already Madam had discussed. A patient is going to hospitalization, some of the acute illness, any acute illness, counter-regulatory hormones are going to increase. It's particularly epinephrine, norepinephrine, cortisol, and steroid. Or ultimately, these are going to hyperglycemia. Ultimately, these are responsible for the decrease the immune function, decrease the wound healing, increase the oxidative stage, endothelial dysfunction, increase some of the inflammatory marker, interleukin first, second, third, tumor necrosis factor. And diabetic itself is a pro-coagulative stage, increase the mitogen sleeves, fluid shift, electrolytes, and ultimately these are responsible for the prolonged hospitalized stay, disability, and even the death. And how will control the blood sugar at least? Definitely. These are some of the, at least particular, I am talking with the acute MI. Once we are keeping the blood sugar less than 11 milligram deciliter with the target, even we can reduce the 9% mortality can be reduced. So that we can, how to manage the hyperglycemia in hospitalized patient. We are categorizing the patient ideally critical, ill, yeah, non-critical. What about patient is critical ill, yeah, hospitalization, insulin is only treatment. What about non-critical? I think insulin, yeah, and insulin, yeah, OAD can be there. What should be target? Definitely we have to treat the target, no treatment, whatever. So that any particular, I am talking with this particular, guidelines of the AACE or ADA guidelines of the particular saying in the ICU patient start the IV insulin if the blood sugar is more than 180. And what about any ICU patient? At least we should keep the target in between the 140 to 180. But lower target, some of the patient is very severe sick and particular surgical ICU, at least little bit we should keep the 110 to 140 is acceptable in the selected patient as long as this can be achieved without the significant hypoglycemia. But what less than 110 is not safe, more than 110 is not acceptable. So that what about the ADA position of the statement of the glycemic control of the non-critical ill? No clear-cut guidelines evidence for the specific glucose goal. And what about the particular non-critical patient on insulin? At least we should keep the pre-meal sugar less than 140 milligram deciliter. A random should less than 180. 180. Some of these are clinical trials. In particular surgical ICU, some of the patients were put on this particular aggressive control of the sugar, or some of the few patients were put on the conventional at least particular, and ultimately they found there is a significant reduction of the mortality and morbidity when we have put on the aggressive control of the diabetes. So that what about these are a nice sugar study. Nice sugar study guidelines is there is a normal glycemic is an intensive care evaluation survival using the glucose algorithm, and that was designed by the ICU patient, and more than 6,000 patients were taken, and ultimately we have put on the two group, conventional group and aggressive insulin group control, and that is intensive control of the sugar 80 we kept up to sugar 81 to 108, and conventional at least typically we kept on 140 to 180, and ultimately that found mortality were higher once we are keeping the sugar less than 110 at least, and hypoglycemia was more common in the once we are keeping the sugar 110, in particular the surgical ICU. These are again, this is particular all the mixed ICU, medical, all surgical, particular that favor. Once we are keeping the sugar less than 110, at least mortality and morbidity in a hypoglycemia episode were more common compared with the conventions of this particular. So what about how to treat? At least definitely. This is insulin is a most effective treatment of the inpatient glycemic control, acceptable to the increase the insulin requirement during the acute, definitely because of the counter-regular hormones are going to increase. So any type of the stress, at least patient is going to any surgery, critical, not critical stress hormone are going to increase. So that first we should start with the basal insulin, because of the basal insulin can prevent the gluconeogenesis or ketogenesis because of the, and at least those can be adjusted with the various categorized to the patient nutritional states, the IV glucose, total parental, enteral and nutritional deficiency. What about? So what about the limitation with the OAD? Definitely because of these no rapid dose of the adjustment, sulfonylurea because of the long-acting chance of the hypoglycemia. So it does not match with some of the meal. Metformin, acute condition, particular the fear of the lactic acidosis. Some of the patient is going to IV contrast, and so I think we should avoid the metformin. Metformin. With the severe ill patient, even the hepatic, renal, CCF, NYS3, 4 is severe critical ill, metformin, and glatazone is at least particular because of it is very long acting, it will take 2 to 3 weeks, and because of the glatazone is a particular cardiac toxicity and increase the fluid overload, intravascular volumes. So then what about the DPT4 inhibitor? Again is a long acting and onset of the action of this one. So definitely, if the patient is critical in ICU, definitely intravenous insulin therapy is a must. So that IV insulin infusion were specific designed for the in-hospital management. Evidence-based studies support the use of the IV insulin, critical ill and coronary and any type of the surgical and medical and particular the ICU, and insulin is a key, at least whatever. So these are common indication of the IV insulin in the hospital. Any decay, non-ketotic hyperspecific, pre-operative, intraoperative, post-operative, already madam had discussed earlier. And organ transplant, our next speaker is going to treat at least what he is going to speak, how to manage the diabetic organ transplant, myocardial infarction, cardiogenic shock, stroke, critical ill, hyperglycemia, NPO, type diabetes, and type 1, type 2, and especially type 2 OAD failure. These are common indications of the health. So what about these are various protocols? These are one of the best power geograph hospital associations and the how to calculate. Definitely this continues the previous diabetic medications. And what about the determination of the intravenous infusion pump unit of the insulin per hour? At least we can calculate blood glucose at a time minus 60 by the multiplied by the at least 0.02 or 0.01 according to the underlying the blood sugar. Blood sugar is high, I think we should multiply with the 0.01, and blood sugar is low, it should be multiplied by the 0.01. Subcutaneous insulin therapy, definitely subcutaneous insulin therapy in the hospitalized effective in hospital glycemic control. Patient can be shifted from the IV insulin to the subcutaneous insulin. Dose is easily adjusted to the basal individual patient needs to the nutrition state. Subcutaneous insulin currently being the sum of the study alternative to the IV in the sum of the mild to moderate decay. So what about these are a various type of the subcutaneous insulin to achieve the glycemic, our magic figure HbA1c 7%. Subcutaneous insulin, as in particular, it contains a basal, prandial and supplementary. What about at least? So basal means the continuous subcutaneous insulin infusion, long-acting insulin, and intermittent is NPH, and prandial and nutrition insulin, that I think short-acting, rapid-acting, or regular insulin. What about Humalog, human Lispro, and Aspart and glucine? A supplementary insulin factor correction component can be managed with the rapid-acting insulin. What about the still is ISO? At least what about the we are seeing there is a typical sliding scale of the pattern. At least whatever I think it should be outdated, at least because of the roller coaster effect of the insulin, because of the it does not provide the basal insulin. Whenever sugar is going to high, or we are going to give the insulin, so the hypo and hyperglycemia, so that we can say once we are putting off the sliding scales, roller coaster effect of the insulin. I think all the ISO patient, at least the basal bolus regime is a normal insulin profile at least. What about at least 50% of the total daily dose, at least we should at least consider as a basal. Rest of the 50% at least it can be divided into our nutritional insulin, and whenever we will take the meal, breakfast, lunch or dinner, at least prior to breakfast, lunch, dinner, it can consider with the short-acting or rapid-acting insulin. We are going to discuss with this particular what about the difference between the sliding scale and some of the basal bolus therapy. These are Rabbit 2 study are showing at least basal bolus therapy is much better and achieve the glycemic index and with the least glycemic variability. So how to shifting from the IV to subcutaneous insulin therapy? Definitely that is a insulin requirement. Suppose the patient is having the healthy, at least most already we have discussed, for blood sugar, at least we have to calculate total daily dose and how to divide of the total daily dose in the basal, prandial and corrections. What about if the patient is healthy, so 40 to 50% of the total daily dose, it can divide into the basal, and rest of the at least 50 we can consider as a nutritional prandial. At least rest of the particular the correction, it depends on postprandial sugar. But patient is sick and less eating, then definitely basal dose should be increased and prandial dose should be decreased, and correction dose are going to increase. Their correction dose is depend upon the underlying the illness. So that how to calculate the switch from the IV to subcutaneous? Initiate the prandial dose of the rapid-acting analog with the first dietary tray, even the patient on the IV insulin. How to calculate with the TD, that is at least 24-hour insulin requirement, unit of the insulin for the last 2 hours of the IV, multiply by the 12. So that we said calculate the TD, at least what about total daily dose at least. And out of this particular 80% should be projected, at least it can be. Out of the 50% considered as a basal component, that is long-acting insulin, so that at least it will be a basal component. Or rest of the at least it can consider the prandial and nutrition component, it is this breakfast, lunch and dinner, and rest of the correction insulin based upon the 2-hour postprandial glucose, and it depends the illness related, at least what. And whenever we are putting of the basal bolus therapy, we should check the blood sugar before breakfast, before lunch, 4 p.m., before dinner, 10 p.m. and 3 a.m. at least what about, and depend upon the according to the That is. So that what about the corrections? These are different formula. What about in the type term? Once we are going to treat the type 1 diabetes, add the 1 unit of the insulin every 50 milligram over the 180 at least. Whatever. That is a simple formulation. In type 2 diabetes, add the 1 unit every 30 milligram over the 180, and particularly the insulin resistance, obese, high BMI, and patient is receiving the high dose of the steroid, at least 1 unit consider 20 milligram deciliter over the 180. That will be at least used as a correction insulin dose. These are a various comparison to the human insulin with the analogues, with the various preparations. It's the short acting is human Lispro asparglucinate, onset of the action 5 to 15 minutes, and peak is a 1 to 2, at least matched with our meals. Regular insulin is a before onset of the 30 to 60, so that it should be given before 30 minutes prior to the meal. And some of the long acting basal and large lentus and levimil, and what about the, at least one onset of the action 1 to 2 hours. There is no peak, and duration of the actions is a 24 hours. How to compare with this particular, the regular insulin has a significant activity after the 4 hours. Compare with this particular, the short acting insulin. What about the sum of the glucose? This is a regular insulin, and this particular human red bar is a regular. This is a short acting, ultra short acting Lispro, Imalogue, and Imalogue is up to the 3 to 4 hours, and this is a human regular insulin up to the 8 to 10 hours. What about the difference between this particular, the insulin Lispro? Insulin is a, when we will take the high calorie pizza, Coca-Cola, dessert, and contain a lot carbohydrate, and peak is going post-prandial sugar is a big issue, in particular our Indian setting, so that the short acting insulin, rapid acting insulin will be better rather than the regular insulin. What about the compare with this particular, the how to efficiency and role of the insulin analog? Compare with the regular insulin, definitely insulin Lispro return the glucose level to the pre-meals value with the half and time compared with the regular insulin. And because at least rise of the 2 hour postprandial glucose was 53% lower than the lower with the human Lispro compared with the regular insulin, at least. And the chance of the hypoglycemia is a less with the Lispro, either human insulin analog. So these are how to management of the hyperglycemic hospital setting, published in New England Journal of the Medicines, and ultimately these are rapid acting of the insulin analogues. Lispro, asparglucinate should be given immediately before the meal, at least whatever, because of 5 to 10 minutes, and prudent approach to the provide the insulin whenever meal tray is in front of the patient. Regular insulin human should be ideally 30 to 40 minutes prior to the meal. And goal that will be very difficult to meet in a busy hospital setting. Rapid acting analog provide the better postprandial control, and in patient who have dietary intake is uncertainly, so that prandial insulin dosing should be conservative. Big issue once we are keeping the blood sugar 140, 180, HbA1c, we are keeping the near to 7%. How to prevent the hypoglycemia is big issue at this water at least. So how to prevent the hypoglycemia? Hypoglycemia is a primary limiting factor for the achieving the optimal glucose control. Reduction of the insulin dose can be required if the patient is switched the nothing by mouth. Reduction of oral intake of the food, enteral feeding is going to discontinue, total parenteral nutrition, IV dextrose are going to discontinue, timing of the pre-meal insulin whenever the meal disturbed because some of the mechanical and some of the patient transfer, and once we are going to taper the steroid, at least I think insulin dose should be reduced to prevent the hypoglycemia. What about our discharge planning from the ICU? Definitely hospital discharge planning with the diabetic, start new insulin regime prior to the discharge, establish the blood sugar prior to the discharge, obtain the HbA1c during the discharging, refer the patient to the certified the diabetic educator, provide the specific instruction of the medication use, provide the instructions to the glucose monitoring, provide the instruction of the hypoglycemia prevention, and schedule the follow visit, at least because of the control of the diabetic require the multidiscipline, and it is a teamwork. It needs the paramedicals and nursing and dietitians and diabetic educator and insulin educator. So that is a hospital discharge algorithm how to determine if on the admission, if the HbA1c were less than 7%, I think continuous pre-admission take drugs. On the admission, HbA1c 7 to 9%. The patient discharged with the pre-admission regime, and we can add the basal insulin 50% in hospital. In hospital Delhi, on the admission, is more than 9%. Discharge on the oral anti-diabetic with the basal and basal bolus therapy with the 80% of the hospital dose. Whatever the summary of the aggressive glycemic management is a critical for optimal glycemic control, while the hospital improve the hospital outcome. But we are going to control, we should keep the 140/80, so the outcome is good. Early detection of the diabetes in patient with the hyperglycemia after the discharge. Insulin treatment of choice for the optimal management of the hyperglycemia of the hospital, and start the IV whenever sugar is more than 140, more than 180. And what about the target in ICU? We should keep the 140 to 180, and it's required the diabetic education, medical nutrition therapy, discharge planning, and essential component of the. Thank you. That is, thank you for hearing me. Thank you.